Bismillah ar-Rahman ar-Rahim. The topic of my presentation will be dental management of irradiated patients. Background about oral cancer. It accounts for 4% of all cancer cases. It's ranking number 7 in occurrence. This is after lung, breast, colon and prostate cancers. Annually, every year in the USA, there is 54,000 new cases diagnosed with oral cancer. And the mortality rate is about 13,500 cases annually. Squamous cell carcinoma is the most common type of oral cancer, and it accounts about for 90% of the cases. And the tongue is the most common oral site for cancer. There are different modalities employed in radiation therapy. There is external beam radiation and there is brachyradiotherapy. In the external beam radiation, we have electromagnetic radiation, example X-ray and gamma rays. They has no mass and no charge. They are electromagnetic waves. And there is particulate radiation like electrons, neutrons, alpha particles and atomic nuclei. They have mass and they may have a charge or not. Like electrons have negative charge. However, the ones that in general use for radiation oncology today are X-rays, gamma rays and electrons. The unit of radiation, formerly the red was used, but now it is replaced by the gray, which is defined as energy absorption of 1 joule per kilogram. 1 centigrade equal 100 rads equal 100 centigrade. External beam radiation, it is either ortho voltage, which has low penetrating power, and the energy ranges about 250 kilovolt. And the super voltage machines produce mega voltage. The energy of the treatment beam is measured in electron volts, which is defined as the energy required to move an electron through a potential of 1 volt. 1 kilovolt equals 1000 electron volt and 1 megavolt equals 1 million electron volt. Usually the patient receives radiation 5 days a week for 6 or 7 weeks. The weekend, which was in Saturday and Sunday, was in the States. The patient take break from the radiation, but the other 5 days he received every day in the range of 200 centigrade. This meaning per week he receive about 1000 centigrade over the treatment. If it's 6 weeks, it's 6000. If it is 7 weeks, it is 7000. You cannot give the patient radiation more than that because there is limiting factor. The limiting factor for the radiation is the tolerability of the adjacent tissue. You can give the patient radiation until you get rid of the tumor, but in the same time you can get rid of the patient himself because there is limit. Every tissue in the body has limit for receiving radiation. Like the spinal cord, he can receive like 5000 centigrade. After that, the patient will have paralysis. So the limiting factor is the tolerability of the adjacent tissue. Brachyradiotherapy, it is divided into interstitial therapy. In brachyradiotherapy, you insert a radioactive isotope in the form of needles or seeds interstitially within the tumor site, inside the tumor, or intracavitary. If it's like in the lung, you insert it inside the pleural cavity, or in the form of surface molds if it is like a skin cancer. In brachyradiotherapy, we're using different types of radioactive isotopes. The one mostly commonly used is iridium-192. We'll speak about a little bit about radiobiology in order to understand what is radiation and what is the biological effect of radiation. When the patient receive radiation, there may be direct cell death because of this radiation beam directly hit the nucleus, affecting the DNA, causing breakage in the DNA, or it can cause affect another part. Not the nucleus is the most effective, more susceptible to the effect of radiation 1000 times more than the cytoplasm. But if it affects another area of the nucleus which is not containing the DNA, or it's affect like part of the cytoplasm like mitochondria or something, it can cause sublethal injury, and if given enough time the cell can repair. But if it go immediately through mitotic division, cell death will occur. Most commonly, if you are speaking about the particulate radiation, like the neutrons and electrons, they mostly cause direct damage to the cell because it has mass. But for the electromagnetic waves which has no mass, this mostly will cause dissociation of the water molecules, which is more abundant in the cell, and cause its dissociation into free radicals, and these free radicals will cause the damage to the cell. Why we are giving radiation in fractions? In the old days, they don't know about the fractions. Everything was empirical, trial and error. They don't know how to give doses. So over time, when they reached that the best way is to do fractionation, this was a major breakthrough. And why we make radiation? For the following reasons. Reoxygenation. They discovered that oxygenated cells are 3 times more sensitive than hypoxic cells to the effect of radiation. And in large tumors, the middle area, the middle core of the tumor contain hypoxic cells. So when we give fractions, every time the external part of the tumor, which is containing oxygenated cells, will die and shrink, and there is greater probability that more cells will get oxygenated and become more liable to the effect of radiation. Also, another cause for fractionation is the redistribution. By redistribution, we have to mention that every cell has a life cycle, and during certain parts of the life cycle it is more susceptible to the effect of radiation than other parts. Like, for example, during the G1 phase and the mitotic phase, the cells are more sensitive to radiation than during the beginning of synthesis of DNA and at the end of synthesis of DNA. So by fractionation, we are having more chance to hit the cell during part of its life cycle in which it is more susceptible to the effect of radiation. Repopulation, this is a phenomenon they discovered that when the tumor is receiving radiation, every time it's shrinking. At certain point, the remaining tumor cells has a tendency to rapidly divide and repopulate. And this is they discovered it in like the 4th week of receiving radiation. And at this time, some protocols now added a booster dose during the 4th and 5th week to control this process of repopulation. Repair. By repair, we are meaning repair of sublethal injury which occur. And this will repair, at least you have to keep 6 hours for repair between the fractions of the radiation. And they discovered that the normal cells has more ability to recover than tumor cells. And as I mentioned, dose-response relationship, always we can give radiation till the limit the maximum tolerance of the adjacent normal tissue. There are many side effects for radiation therapy to the head and neck. Example, xerostomia dry mouth. It is a common occurrence and long-lasting. Salivary gland has acinar cells and mucus producing cells. The acinar cells are more affected by radiation than the mucus cells. The pH will be more acidic and there is 80% reduction in salivary flow. How to manage it? By using sialogogues like pilocarpine tablets, which stimulate the surviving acinar cells to produce more saliva. Also by chewing sugarless gum, using artificial saliva, and always drinking a lot of sips of water, and by organ engineering, in which they change the mucus secreting cells into acinar cells by injecting a water channel gene inside these cells. Mucositis, it's a common occurrence, but usually subsides 2 to 8 weeks after therapy, and it varies in severity. The management: shield metallic restorations. Mild to moderate mucositis can be managed by blend diet, avoid alcohols and tobacco, topical anesthesia, like 2% viscous xylocaine solution, and a useful mixture consists of 2% viscous xylocaine acting as topical anesthesia, Benadryl, anti-inflammatory, and protective mucosal coating. Severe mucositis may require interruption of treatment, and interruption of treatment, unplanned interruption of radiotherapy, is very annoying to the radiotherapist because it allows time for repopulation of the tumor cells. This figure shows mucositis. It's a very painful condition, and I noticed the patient always mentioning like they have pizza burn. Radiation cares. Whenever there is xerostomia, you will find radiation cares. It's a common occurrence and starts 3 to 6 months after therapy. There are two patterns detected: either cervical decay or heavy brown black discoloration. The management: good oral hygiene, topical fluoride application, remineralization solutions, periodic checkup, filling of cavities, and root canal treatment for cavities with pulp exposure. This figure shows the heavy black brown discoloration due to radiation cares. We have to use fluoride carriers for such patients, applying on a daily basis 1% sodium fluoride gel. Ageusia, which is loss of taste sensation, or hypogeusia, this is common occurrence that start within the first 2 weeks and gradually return after 3 to 6 months after completion of therapy. There is 90% loss of taste acuity, 10% loss of taste cells, and 30% loss of taste buds. The management: prosthetic appliance that displaces and or shields the tongue. Candidiasis, it's a fairly common complication that may persist for a long time after completion of treatment, especially with severe xerostomia. Management: good oral hygiene and frequent rinses with saline or chlorhexidine gluconate. Keep removable appliances clean. Mild to moderate cases are treated by topical application of antimycotic suspension, such as nystatin. Severe cases will be treated systemically by fluconazole or ketoconazole. Here the figure shows candidiasis. Trismus, it's a rare complication, more often if surgery is combined with radiation, more often if TMJ and muscles of mastication were in the field of radiation. It is due to fibrosis that occur in the masticatory muscles. Management: isometric exercise for mild cases. More severe cases require mechanical devices to stretch the musculature, such as the cerabite. Trismus may be due to recurrent or metastasis. Notice always you have to inspect the patient for any metastasis. This figure shows a cerabite, which is a very successful appliance for increasing the range of motion. A very simple appliance is placing tongue blades between the patient's posterior teeth and keep it for like 5 or 10 minutes every hour, and when the mouth opening increases you add more tongue blades. Here in figure 3.6 you will find a dynamic mouth opener, and it's very effective also for decreasing trismus and increasing mouth opening. Anorexia اللي هي فقدان الشهية للأكل and malaise تعب, uncommon complications that occur during treatment and may persist for long time after completion of treatment, especially anorexia. Tooth sensitivity, uncommon complication which occur 4 weeks after starting radiotherapy and may persist for long time. Management, desensitizing toothpaste such as Sensodyne, topical application of fluoride gels, dentine bonding agents. Alopecia or hair loss, it is a common occurrence, but partial recovery is possible. Edema, fairly common occurrence with tumoricidal dose of radiation and is seen during treatment and occasionally persists after completion of therapy. Epidermatitis, the skin is affected by radiation because it's rapidly dividing cells. This starts within the first 2 weeks of radiation and is seldom long-lasting after completion of therapy. Dysphagia, which is difficulty in swallowing, it's a fairly common occurrence because the alimentary tract, as we mentioned earlier, is rapidly dividing cells and will be affected by the radiation, and it may persist for a long time after completion of therapy. This figure shows epidermatitis. It's like a severe sunburn. Herpes simplex, reactivation of the herpes simplex virus is a rare occurrence. It can cause recurrent and severe lesions in immunocompromised patients. That's why for small herpetic lesions, we treat it by Zovirax ointment, 5% acyclovir, but in progressive severe cases or in immunocompromised patient, we use systemic acyclovir. Osteoradionecrosis, this is the most serious complication of radiation, but it is not common. So when I ask you, osteoradionecrosis is a common complication, your answer will be false. But if I said the osteoradionecrosis is the most serious complication, your answer will be true. It is a radiation-induced, non-healing, hypovascular and hypoxic wound. It is a serious, rare complication. More in the mandible than in the maxilla, because the maxilla has collateral circulation and the mandible has only one blood supply from the inferior dental artery. The classical sequence of its pathogenesis was radiation, trauma, and infection. In the old days, they thought when the patient receives radiation, if you get trauma and there is exposed bone, bacteria will come and infect the tissue. This concept is not correct, because if it's correct, the patient will respond very good to antibiotics, but this is not the case. The new concept developed by Robert Marx in 1983 is that when the patient receives radiation, his tissue will be hypoxic, hypocellular, hypovascular. This we call it the 3H principle. And whenever tissue breakdown occurs, either to trauma or spontaneous, tissue breakdown can occur in 39% of the cases spontaneously, there is chronic non-healing wound because of the hypoxic, hypocellular tissue. It will not have the ability to regenerate and cover this defect. infection may come on it, but the exact cause is the 3H principle. Prevention: eliminate all sources of dental infection prior to radiation therapy. Stress and maintain oral hygiene. Allow adequate time for healing of extraction site prior to radiotherapy. If you are going to do extraction before radiation therapy, you have to do extraction and do a little bit of alveolectomy, so you will close the wound without tension. I don't want any sharp bone spicule projecting from the gingiva. This will cause later on exposure of the tissue and osteoradionecrosis. And you have to allow time for healing from 14 to 20 weeks before starting radiotherapy. If extraction deemed necessary after irradiation, it should be done in conjunction with hyperbaric oxygen and antibiotics. What is hyperbaric oxygen? You go, the patient goes through a chamber containing 100% pure oxygen at 2.4 atmospheric pressure, and he stay in this chamber breathing pure oxygen for 90 minutes. They call it dive. This 90 minutes, they call it dive. HOTS. The protocol usually is to receive 20 dives before the extraction. Before, if you are placing like dental implants, you receive 20 dives before placing the dental implants in irradiated bone, and after radiation you receive like 10 more dives. And if you are going to do extraction after the patient receive radiation, of course if you do extraction before receiving radiation, you don't have to do hyperbaric oxygen. But if it's deemed necessary to do extraction after irradiation, the patient has to take hyperbaric oxygen treatment to decrease the risk of osteoradionecrosis. If the patient has metallic superstructure, he place implants and have metallic superstructure. If it is able, if it's like a removable appliance or fixed removable, you can remove the appliance. But if it's fixed, you cannot remove it. You have to shield this appliance, this metal superstructure. The treatment for osteoradionecrosis, the conservative therapy was in the form of antibiotics and mouthwash, and this doesn't work because it does not address the exact reason, the pathogenesis of osteoradionecrosis. Another old example of treatment was drilling holes through irradiated non-viable mandibular cortex into the viable medullary bone on the hope that this viable medullary bone will produce fresh blood and will cause healing, regeneration of tissue and granulation tissue, and it will heal this osteoid necrotic bone. But this does not occur because you are drilling in non-viable bone, which is hypoxic, hypocellular, and hypovascular. Finally, the protocol by Marks is used in treatment of osteoid in conjunction with surgery. They are using hyperbaric oxygen. The role of hyperbaric oxygen: it is used as adjunctive modality for treatment of osteoradionecrosis. As I mentioned before, 100% pure oxygen at 2.4 atmospheric pressure for 90 minutes. It has a role, it is bacteriostatic or bactericidal, and increase oxygen-dependent leukocyte microbial killing properties. It stimulates the leukocytes to attack the bacteria. It relieves, eliminates orocutaneous fistula, and achieve osseous union in pathological fracture. It increases oxygen tension in tissue, stimulates collagen synthesis and angiogenesis. In Egypt we have I think hyperbaric chamber في مستشفيات القوات المسلحة فيه، وفي كمان في معهد ناصر. And sometimes some doctors there are using it for treatment of diabetes, the hyperbaric oxygen, and it's producing good results. It decreases the level of the sugar in the blood. This figure shows osteoradionecrosis around the dental implant because the dental implant, which is a metallic, will act as a hot spot, increasing the dose of radiation around the implant, so the bone around the implant get osteoradionecrosis. Here is osteoradionecrosis in a completely edentulous mandible. This is a very annoying position. I have met it in my life like 3 times. This photo is with Professor Robert Marks. Soft tissue necrosis, rare complication, present clinically as non-healing ulcer secondary to soft tissue necrosis. The management either by hyperbaric oxygen alone or hyperbaric oxygen in conjunction with surgery. There is oral care protocol for patients who receive radiation therapy of the head and neck. Which patient will be under this protocol? Patient with newly diagnosed head and neck malignancy, patient with persistent or recurrent disease, patient with evidence of metastatic disease to the mouth or associated structures, patient with requirement for maxillofacial prosthesis, like patient with obturators, post-radiation patient, patient with osteoradionecrosis. Coordination of care. Dental consultation is mandatory before radiation therapy. Any patient who is going to receive radiation therapy should have dental consultation before doing radiation therapy. Modification of the usual sequence and nature of dental care may be required, and a report should be sent by the dentist to the referring physician. هتقول له أنا هعمل إيه وهاخد وقت قد إيه. طبعا you are doing the necessary treatment. يعني في الحالات دي مش عايزين فزلكة. واحد بقى يجي يلاقي ستين صغير عايز يعمل بليتشنج ولا عايز يعمل فينيرز وبوست اند كور. البيشنت ده عنده تيومر. the soon you start radiotherapy is better for him. وبعدين any questionable doubtful teeth اخلعها. ما تحطش نفسك في ريسك انك تحتاج تخلع بعد الراديشن، لان ده ممكن يعمل osteoradionecrosis. Dental management. Complete dental assessment before radiotherapy. Pre-radiation dental treatment should include necessary extraction, filling, endo, and prophylaxis. Inform the patient physician about the type and extent of dental treatment. Panoramic X-ray should be done to all patients. If the patient will have surgery in conjunction with radiation, هتاخد impressions وتعمل له surgical obturator. ايه الفاكتورز اللي بتحكمك تخلع السنة ولا ما تخلعهاش؟ الستيج اوف ديزيز اند اتس بروجنوزس. يعني المريض في حاله تيرمينال خالص وانت عارف ان هو يعني الراديو ثيرابي دي مش هتجيب نتيجه معاه، طبعا مش انت اللي عارف، اللي بيقول لك على الراديو ثيرابيست. في الحاله دي ما تخلعش، ما تقعدش بقى يعني تعذبوه خلاص. general health of the patient. واحد عنده systemic diseases، حاجه blood dyscrasias، ما ينفعش تخلع. انت بتخلع السنان اللي هي اوعى تخلع سنه within the tumor site. يعني واحد عنده تيومر مثلا في الليفت سايد اوف ذا ماند وفي سنان داخله في التيومر، اوعى تخلعها لان دي هتعمل ديسيمينيشن للتيومر. انت بتخلع السنان اللي مش ويزن ذا تيومر سايت نفسه، اللي هي هتبقى في الفيلد اوف راديشن. الفيلد اند دوز اوف بروجكتد راديشن. افرض السنان دي مش في الدايركت فيلد اوف راديشن، غير ما تكون البيشنت هياخد هاي دوز اوف راديشن والسنان دي في الفيلد اوف راديشن، دي حاجه ثانيه. ability of the patient to cooperate to implement preventive measure. يعني ايه؟ جالك patient with very poor oral hygiene، ده الكلام ده قبل ما ياخد راديشن. ما بالك بقى لما ياخد راديشن ويحصل ميكوسايتس والانفلاميشن والكلام ده كله والالسريشن، هيقدر يعمل اني ميجرز؟ لا. والحاله دي هتشيل كل اسنانه كليرنس. اوكي، ففي حاجات بتحكمك هتخلي السنه ولا هتشيلها. طب الكومبليت دينشر فور irradiated بيشنت. جالك بيشنت واخد كيموثيرابي راديوثيرابي وعايز يعمل دينشر، امتى تعمل له؟ في النورمال ما بنعملش الدينشر قبل 2 مانثs، لكن في بعض الاحيان انا ممكن ما اعملش الدينشر خالص، يعني ممكن اجله لغايه سنه او 2 وممكن ما اعملوش خالص. هنقول السيناريو، هنقول تو سيناريوز وانت احكم بقى بنفسك. جالك بيشنت واخد هاي دوز اوف راديشن والماندبل was in the field of radiation. البيشنت ده has thin wiry ridge, knife edge ridge, pale atrophic mucosa. He has multiple extractions before receiving radiation and he never used the denture before. في الحالة دي كل الريسك فاكتورز موجودة. انا في الحالة دي مش هعمله دنشر غير لما احكم على الحالة بعد سنتين ثلاثة، ويمكن ما اعملوش خالص لانه ممكن يعيش كده وياخد حاجات سوفت دايت احسن ما تعمله دنشر ويحصل تروما ويحصل اوستيورينري كروزس والبيشنت يضيع فيها خالص. السيناريو الثاني جاي لك بيشنت واخد لو دوز اوف راديشن. The mandible was is not direct field of radiation. Very well developed ridge. Thick fibrous mucosa. البيشنت كان لابس دنشر قبل كده وعملش multiple extractions before radiotherapy. فالحالة دي اعمل دنشر within the first 2 months وما يهمكش حاجة خالص. طب ايه البروستاتيك كونسيدريشن اللي خلي بالي منها وانا بعمل كومبليت دنشر لواحد واخد راديشن؟ نمشي ستيب ستيب. في البرايمري امبريشن اعملوا الجينيت، ما تعملوش امبريشن كومباوند عشان ممكن يعمل لك ثيرمال بيرن للبيشنت. هتعمل بوردر مولدنج but guard against over extension، وهتعمل بوردر مولدنج بباتي ميكس. لو هتعمل بجرين سي كومباوند تدهنه بفازلين قبل ما تحطه فوق البيشنت to avoid thermal trauma to the patient. You will use mucostatic impression technique. You will always use a spacer in the special tray. Final impression you will make it with rubber base. Do not use zinc oxide eugenol or plaster of Paris because they has drying and irritating effect to the mucosa. When we are taking the bite, we will make it with the wax wafer technique and we will decrease the vertical dimension slightly. This will decrease the masticatory force, and because this patient usually suffer from some degree of trismus. Use monoplane occlusion to avoid any lateral interference, which will make the denture less stable. So monoplane occlusion is better in completely edentulous patients. Avoid using soft liners as permanent bases because this patient will have xerostomia and the soft liner will have a dragging effect on the mucosa زي ما يكون كده كاوتش بيفرمل على اسفلت. Do laboratory remount or clinical remount before delivery. Pressure indicating paste to check pressure area. But if the patient has severe xerostomia, you will use disclosing wax, not pressure indicating paste. Lightly polish the fitting surface of the denture. Denture and oral hygiene instruction should be given. You will do daily examination for the first week and after that follow up every 3 months. Thank you.